Okay, great. Good morning, everybody. It's a big pleasure to moderate this session, which is a very, very interesting session. We will talk about secrets of filler use with very important opinion leaders who have a great experience on injecting the face of our patients. We have to know how to achieve the best result, injecting in the right place the minimum amount of fillers they need. So I think that, of course, we have to know very well the anatomy and what is behind it. Great. So as you can see, we have great opinion leaders. I thank all of them to be here with us. And I don't want to steal time to this session. And I want to invite Professor Sebastian Cotofana, who is an anatomist and trauma surgeon, to introduce the session, telling us something about the anatomy of the face for our best results. Thank you, Dr. Cotofana.
So thank you, Professor Bartoletti. This is really a great pleasure and honor to be here. And I think in these times of claiming that someone is difficult or not and doing these divisions, I think it might be important to understand and to emphasize what actually do these patients have in common. And I think this is one of the important aspects, especially in these times. And not that I say this because I'm living in the US and these times are very tricky here to identify what is common amongst everyone. But I think even anatomy can help us to look at what is about a difficult patient. So I have no conflict of interest because I'm an anatomist. So I'm just talking about what everybody have within the face. And let's see what is common among us. So we have the layers of the face, which is one important aspect. And the layer of the face, which everybody has, is important to understand that treatments that we do in the upper face will somehow influence the effects in the middle face and in the lower face, because these layers are connected, right? And if you look at these ones, how these layers are really continuous, starting from the scalp, going down through the temple, down through the mid face, lower face, and into the neck, they all are connected. And this kind of shows us, yes, all of these layers are connected, and these structures can co-influence each other. And if you think this is just applicable for the lateral face, actually it's applicable everywhere, which includes the fact that even from the forehead, from the temple, everywhere, all of this is kind of just one layered arrangement of face, which is important for us to understand when we think about what is really difficult about a patient. And of course, a big trend today is about the fat compartments. But of these fat compartments, we need to understand that we have superficial fat compartments. And these superficial fat compartments are located subdermally, which is here indicated by layer number 2. So we have the subdermal, or also called the superficial fat compartments. And it is important to understand that these fat compartments, they are different in their mobility. The red one, which is the superficial nasolabial, and the blue one from previously, which is the jaw fat compartments, they are highly mobile. But this one, this blue one, which I'm pointing now, which is the malar fat pad, is less mobile. So we have differences which are applicable to every patient of fat compartments which are more mobile and less mobile, which give rise to specific structures like nasolabial fold, like the jaws, like the marionette line. All of them here can be explained by the biomechanics of the superficial fat compartments. And of course, we don't have only superficial fat compartments, we have also deep fat compartments. And the deep fat compartments are located here in layer number 4, which is deep to the mass. And of these deep fat compartments, they are located around specific structures within the midface. And all of them are located within the midface around ligaments, around the angular vein, around the infraorbital neurovascular bundle. All of them are in these respective deep areas of the face. But, and we published this a couple of years ago, but all of these fat compartments and all of these layers need to be attached to the bone. And for this, we have ligaments. And I know when we talk about ligaments, everybody talks differently about ligaments. Some of them are multiple, some are less, what is really true osteocutaneous, false osteocutaneous. But I think it's important to understand that the majority of the ligaments can be reduced to just 4. which are from the temple to the orbit to the zygomatic arch to the mandible. These four are attached to the bone, and these four attached all of the layers to the respective bone. And what is very important, and we showed this last year, is that these ligaments can be arranged in a line. I call this the line of ligaments. And this line of ligaments is very important because this helps you to identify and treat a patient more precisely. And we did that actually recently, and we published this in a study where we injected in one patient, same injection points, but one side we started in lateral to the line of ligaments, and the other side we started medial to line of ligaments. So kind of same injection points, but just different sequence. And we found out is if we start lateral first, we need less volume in the medial midface to volumize the midface. The reason is the lateral phase acts as majorly as a lifting component, which then you can reduce the lifting in this area. And when you have this lifting effect, you can precondition the midface to achieve better effects in the midface. It's kind of, they just co-influence each other because of the influence of the superficial fat compartments and the influence of the layers of the face. And again, injections lateral first will precondition the midface and will give you superior results. And then, of course, when we come to the fact, when we look into patients' faces, we always have folds and sulcus. I mean, it's always tricky. How do they come? Well, one of the things is we need to understand is the muscles, because the muscles originate from the bone. Actually, all of them except frontalis muscle and risorius, all of them originate from the bone and they go into the skin at some point. And what they do when they go into the skin is they form connections to the skin. And these connections to the skin result in the fact that we have sulcus, like the nasolabial sulcus. This image shows a histological cross-section through the nasolabial sulcus, and you can see actually muscles insert into that respective area. And you can see that right here. The same thing holds true for the labiomandibular sulcus. Muscles insert into that respective area, and if you remove the overlying soft tissues, you can see their connections to the overlying skin. And now this makes sense why we do have this, right? It's not about the difficult patient, it's about understanding the anatomy, which we have in the different types of subcutaneous arrangement, right? Which was published in 2003 by Qasimi, which is a very interesting paper to read about. And now we come to one of the most important aspects, soft tissue sagging, because this is where we need to fight gravity. And gravity is always a big opponent of aesthetic procedures, but how does it work? So we have bone, which is the fundament. And with increasing age, we just lose bony fundament, both in the midface and in other areas of the face. And all of these underlying aspects which create the fundament result that the overlying skin and the overlying fat compartments start to sag. They just go down. And this is one of the reasons why with increasing age, we just lose the fundament. And if we move on to the next slide, that would be fantastic. Yes. We can see actually that even not only clinical observations, but also the science provides us evidence that this happens. For instance, we published a couple of years ago the study where we shows the height of the midface, the area where we all of them want to treat, and where we all of them want to volumize this midfacial fat compartments. The height of the midface reduces just because the bone goes away, and we showed that. And what is even more important is even all of the support for all of the overlying layers. Hello. All of them here, all of them, they lose their fundament because the calvarial volume also decreases. So that means bone contributes substantially to this. And when you think about this, bone reduces in fundament and we have mobile fat compartments. It explains why we have sagging, why we have nasolabial fold, why we have marionette. This is all the underlying anatomy. And this is why it's important to understand that, yes, we do have difficult patients, but it's difficult from the point of view of treatment. It's not in a difficult point of view understanding, but because if we understand this, all of them would make sense. It makes sense why we have this marionette line, right? And it's a very important aspect to understand. And to summarize all of this, there is rarely a really difficult patient, unless the patient has some other issues. But the difficulty arises in the fact that we need to understand the patient. We need to understand the science behind it. We need to put all of the components together to create kind of the full picture, holistic picture of the face. And if we understand this, then we can treat accordingly and with significantly better outcome. And how do we do this? We will see now in great examples of clinical case studies, which will follow following my presentations now. And with this, I would like to thank you very much for your attention.
Great. Thank you, Dr. Cotofana. It has been a very interesting lesson because anatomy is the basis of our job, of our ability to improve the aesthetic of our patients. So, and anatomy, as I said when we started, is very important because we have to optimize the amount of filler we use. I think one of the most important things you said is that you should start injecting from the lateral part of the zygomatic area and never start from the medial part. And this is a mistake that many people still does. So thank you again. If you have any question for Dr. Cotofana, he will leave immediately after. So if you have any question, just write it down here. No questions on anatomy for the moment. Exactly, everything was very clear. So
thank you very much.
Thank you again, and hope to see you again.
Oh, for sure. Virtually, I hope at some point, but also at some point in person when this all is over, right?
Yes, it will be. Thanks. And now I give word to Marina Landau. Everybody knows her. She is a very famous dermatologist, and she is very well known in all aesthetic medicine in the world. So thanks for being with us, and you will talk about the mid-face and nasolabial fold. Go ahead. Thank you.
Thank you very much, Professor Bertoletti. It's a pleasure to be here. I want to thank FillMed Laboratory for supporting this activity. And Chris, Sebastian, don't go yet, because I will show what the real life is. I think anatomy is very important. I completely agree that it's a basis of what we are doing, but real life is a little bit different. My patients come into my office and they never say, you know, doctor, do whatever you think I need and I will pay for everything. Usually they come and they ask, do the minimum so I can look as beautiful as possible. So in most of the cases, we need to choose where to start. And this is what I want to talk about today. Let me see if I can move my presentation. Not really. Okay. So this is the patient. She came into my office. She has been treated previously by a different doctor, and she complained that she was not really happy with the outcomes of the previous treatment. And looking at her, it is clear why, because she has actually volume loss in the mid-face, and she has a deepening of nasolabial folds. So the question is where to start. If the patient has unlimited financial abilities and she can take a little bit more aggressive treatment, so I will probably address both areas. But real life is different. We need to choose. So how do I choose where to start? Mid-face augmentation or nasolabial? I think it's a real question that each one of us is facing every day. And again, it's a female patient, a male patient, deepening of nasolabials, mid-face volume loss. Where to start? Here or here? So this is what I do. I'm doing what I call a smile test. I give a patient a mirror and ask her to smile. And then I ask her, when do you think your face is more attractive? When you smile or without smiling? And this is it's an extreme simplification of a very complex process that is happening in our faces as we smile. So I ignore everything except to what is happening in the mid-face, in the nasolabial fold. Because when we smile, we have, let's call it artificial augmentation of the mid-face. At the same time, nasolabial folds are getting deeper. So if the patient says, listen, I prefer my face smiling, it means that I need to start with mid-face augmentation. About 20% of the patients reply, I never smile. I don't like my face smiling, which means for me that I need to target first the nasolabial folds. Of course, different other things are happening in our face when we're smiling, but I just want to concentrate in the mid-face. And I think this is a very simple, practical test that each one of us can use to decide what is going to be the first step of injecting filler. And why I'm just talking about this issue, because in 2008, there was one of the first studies, anatomical studies, published in PRS by Rowland and Payne, in which they actually augmented mid-face, claiming that by augmentation of the mid-face, we addressed the nasolabial folds as well. So in 2008, all of us stopped treating nasolabials and switched completely to mid-face augmentation. And I think that it was a mistake, because looking at this, I just don't know why we went back. So looking at this photo, you see it really looks like by injecting saline in the mid-face of this cadaver, the nasolabial folds got a little bit less deep. But in real life, if you look what happened here, the nasolabial folds are supported by the needle. It's not an effect of the filling of the mid-face. So it was, in my opinion, a big fake. And Val Lambros, years later, 2018, he actually showed by this very nice practical, not cadaver, real life study, in which he actually filled mid-face, looked what is happening in nasolabials, and he showed that nothing is happening in nasolabials when we filled mid-face. So it's not indirect effect, Professor Cotofana talked about indirect effects. Indirect effects are very minimal. We can improve overall appearance of the face by augmenting mid-face, but if the patient needs nasolabial correction, it is not going to be corrected by putting volume in the mid-face. And I think this is two prototypes of two patients, one who needs really mid-face augmentation and the other one needs nasolabial correction. And I almost thought to skip this because Professor Cotofana actually talked about it. We know all that deep medial cheek compartment deflates with aging in the both upper and middle and lower third, but especially in the middle third. And this is visual expression of medial fat compartment deflation. We see this patient, and again, it looks like nasolabial compartment becomes bigger, which really is happening. Mid-face is emptier, and nasolabial folds are also existing here, but it is, in this case, it's indirect result of mid-face deflation. How do I correct this patient? Again, I use art filler volume for this correction specifically, and there are two options. One is vertical injection technique using a needle with supraperiosteal bolus injection, that direct vertical injection in the space in which these two lines meet, and this is mid-face compartment volume augmentation. And this is how it is performed. Oh, sorry, and this is the second approach. Second approach is using cannula more superficially, addressing basically the same area. Again, how I choose it, again, I'm looking at the faces, very mimetic faces. I would do it deeply, less mimetic. You can do it superficially. And this is some of the before and afters by correcting mid-face volume loss. And this is the patient that I presented, was my patient first case. In this case, I actually augmented mid-face. She liked her face when she smiles. And now the patient is really happy because I addressed the major problem of her face. and this is the male patient that I showed before. All this patient needed mid-face volume augmentation. Now let's go to this patient. He does not need mid-face volume augmentation. He never smiles because he didn't. When he smiles, the nasolabials got much deeper, and he did not like that. But this is a very particular kind of nasolabials. I call them paradoxical nasolabial folds, because in most of the patients, the normal nasolabial folds are usually deeper in the upper part and more superficial in the lower part. The paradoxical ones are those in which the lower part is deeper than the upper part, and it requires a little bit of different technique to correct them. So I use subdermal injection, horizontal injection, so horizontal to the fold, not along the fold. A firm technique being described years ago, which is a modification of horizontal in the injection, and I use FillMed Art Filler Universal for this purpose. And you can see this patient before and after. Actually, he is after 1 year, because he came for the next injection after a year, and you can still see that the correct selection of the treatment area, correct product, and correct injection technique provides a very correct and long-lasting results. So to conclude, patient assessment and understanding with the particular and specific problem is the basis of the success of our treatment. We need to choose the right product, the right zone of treatment, and the right technique. Thank you very much.
Great. Thank you. Thanks a lot, Marina. It has been a very interesting lecture, because the middle part of the face is always a challenge. Sometimes too often, I think, we find people overfilled in the middle part of the face. So I think that judging exactly the indication is very, very important. So thank you a lot. Then I wanted to introduce Alessandro Gualdi, who is a plastic surgeon from Italy, and he will tell us something about another challenging area, which is temporal and the periorbital area.
I guess if I ring
Thank
wrong.
you, Alessandro. Go ahead.
I want to say thank you to Emanuele Bartoletti, a very good friend of mine, and to all the other colleagues. I'm a plastic surgeon, and I'm going to show you my approach about these two difficult and tricky areas from my point of view. And I consider this area, the temple, and of course the periorbital area, as the Dr. Landau just spoke before, like a very key point in the facial rejuvenation. I'll show just to treat the different area and to treat the different layer of this area in the different deep of this area. We just use different products, and we are just going to show you our personal approach with the different art filler when they use the volume and the biggest amount of that, then universal sorry, for the surface, and NSCTF just to make the last touch, okay, the reminiscence of the small wrinkle of the texture on the skin. Just again, like Sebastian showed before, what's happened during the aging phase is we are all of us are agree about that, and Sebastian showed us in a very good way. The problem is, of course, the elastosis of the skin, but the big problem is just the losses of the volume would start from the bone, of course. And we saw what's happening in the temple, and we saw what's happening in the orbital frame. When I describe what's happening in the frame, in the temple to my patients, I describe them, but what is happening, that they are deflating in this area, and the orbital became wider, like the Ray-Ban pilot glasses, you know, in this direction. And for this reason, we have the losses of the volume and the prominence of the orbital bottom, and of the zygomatic prominence. And all this just exiting in a sedging loss of the fullness. Okay. As Manuele told before, I'm a plastic surgeon, and I love to do surgery on the face, and that's also my business and my biggest interest in that. So generally, these two areas are quite tricky. Okay, are not like the neck and not like the bleph. So we have just we can treat also the mid-face area with the surgery, but of course we have to be able, from the technical point of view, sometimes also with the mid-face, it sounds easy, but the difficulty of this point is just to manage the patients and to manage the healing and the downtime of this surgery. So for this reason, of course, we can just treat this area with lipofilling. Also, it's just a small surgery procedure. But why not? We can find and we can work on this way just to find an anesthetic approach with the medicine and of the filler. Okay, so the idea is just to fill up. This is what at the last we do, the area that we treat, and of course the result is quite similar to surgery. The downtime is faster than 10 times before. So the idea is, you know, maybe you don't know, I'm from Milano. Okay, Milano is the fastest city of Italy. Okay, and the patient who comes to us, they want to be ready not tomorrow but the day before. Okay, so also the browsing sometimes could be a problem. Of course, we have just to lead our patients and to explain them. But the browsing and blue spot are the minimal problem that we can have. But they love this kind of results, and we are going just to treat the area, just to fill it up in the very specific point. This is what, of course, allowing the temple in an early sinus aging that we corrected can lead to significant patient and practitioner satisfaction. This is the idea. Okay, the idea is just to put the product in the right layer, in the right volume, in the right point. Of course, it sounded easy, but I want to show you. My idea is just to fill up the temple, put the product deep in the muscle, directly in the deep surface between the deep temporal aponeurosis and the muscle. In that point, I'm going to show you on the cadaver specimen. I hope the video can show you. Okay, I've already done the bolus. We lift the skin, the superficial temporal fascia, and the temporal muscle. We see the superficial aponeurosis, the bone and the periosteum, and now we make the incision of the deep aponeurosis of the temporal muscle, and we find our bolus. So the idea is to touch the bone, to retrieve a couple of millimeters, to stay very firm, and to inject the bolus just directly above the deep temporal fascia. The deep temporal aponeurosis. Okay, and that is the area. I will show you. I'm sorry. This is a video. Maybe there's the audio on. And we are going to treat this area with the volume and the CTF. Now let's see if it starts. Yeah. Okay, the video is here. Sorry. Okay. I hope of what's happening in the aging phase in this area, in the temple and the forehead. So the idea is just during the aging phase, what's happening in the skull is the first one is going to the fall in this part. So, especially in the cross line between the orbital rim and the temporal cresta. So the idea is just to fill up this specific area directly here, and to refine it here, and if we need it, superficially with the cannula. The other part that we are going to fill up is just, we are going to treat this area. You know, the zygomatic prominence lose his prominence during the time, and for this reason, we are going to reshape this. This is the cross point between the orbital rim and the temporal crest. This is the point, and we're just going directly, perpendicularly to the center of my heel here, okay, with the volume 0.7, and generally 0.5 to 0.7 if we need it, of course more, and another small dot here, just backwards, 0.3 or 0.2. So one vial just only to fill up this area. If ultimate all the stuff, all the work in this area with an NSCTF in the small wrinkle to have a rejuvenation of all the orbicular part and the surface. So let's see which way we do that. Area, in the temple and the forehead. So the idea is just during the aging phase, what's happening in the skull is the sorry, does it happen again? Okay, if we need it, sorry, with the volume. About this
the
area,
treatment of the
infraorbital
area.
Mid-face area, we will just jump with the one ball directly perpendicular to the bone. We touch the bone, we retrieve it in a very small millimeter, and we put a small amount of product. Small amount is just around 0.2, 0.3. About the vascularization, we have of course to be careful about the superficial temporal artery. We just become from here to here, and then we just got some dilatation to this area, and to deep temporal artery, of course. Our point, injection point is here. We go very deep, we retrieve the needle, and we make a small aspiration, like always. The safety first. The skin of this lady is very transparent. For this reason, we see also the superficial vessel, and we have to very carefully move between these. So to don't stick that, to avoid any bruising in the next days. So perpendicularly, we touch the bone, we retrieve 1 millimeter to inject directly in the deep surface of the muscle behind the deep temporal aponeurosis. That is the space in which one we want to inject our bone. And you see, that is the first correction. And the second one is here. Again, perpendicularly. We feel, we just go through the first aponeurosis of the temporal muscle, and then we feel the second one directly just attached to the bone. We retrieve 1 millimeter and we inject the rest of our veal here. And that is the effect. I don't know if you can just actually immediately appreciate the result, how this area is the fill up, and also the eyebrow wing. How is it? Here it's just on the orbital rim, here it's just a couple of millimeters above the orbital rim. That is the effect of the inflection of this area. The idea is just to carefully put our finger on, and we just go directly here.
Our finger on the pedicle, of course, or the infraorbital pedicle, just to protect it.
The bone. We of course, sorry, because I want to just show you what I'm doing. We make the aspiration, and then 0.2, 0.3. We just mold a little bit.
Okay, sorry that the red dots was just the pedicle. Of course, we have just always to be careful to the safety, and we have to know the anatomy, of course, and where the vessel and the vascular pedicle going. Sorry again. Okay, this is the result about the. I'm so sorry. It's not easy just on this clear face just to show them the effects, but of course they're not amazing. But the patient is really happy. We correct all the space you see, the hollowing here, and also this new shape is correct after the treatment. Maybe also we will going just to have a correction of this most wrinkle after with another treatment of the NSCTF. And other patients, we will see again the prezygomatic area and the orbital area, sorry, the temporal area. You see, you can see how the hollow is following now, the fullness of the hollow there. And I want to say thanks just to, this is how my approach, and this is just a couple of the results just to understand the idea. Of course, the study of the anatomy from my point of view, is the basis is to treat in the safety of the face and to be able to inject all the products. Thank you.
Thank you, Alessandro. Thank you for and compliments for your presentation. I think we will have time at the end of the session to discuss all the doubts that our colleagues have, because we have to improve our knowledge on these topics. So next speaker is Frédéric Braccini. Hello, welcome. And I'm very plastic surgeon, and of course everybody knows him. And he will talk to us about how to preserve the natural with millennials, which is not quite easy. But anyway, we'll try.
Okay, thank you, Emmanuel. Thank you, my dear friends. This is always a great pleasure to take part to some FillMed symposium. And I will try to speak about this highlighting approach, which is a subtle evolution in the management of the aesthetic medicine. I try to, okay. So all of you know that we are changing the concept of the beauty, the management of our patients, and we are all running in the same direction towards minimal invasive procedure, and in order to preserve the natural for all the patients. The trends are to, in fact, to perform minimal procedures, to erase specifically the shadows of the face and the folds, to erase, in fact, the negative expression of the face, and in the same time to be able to play and to restore the volumes and light control of the face. But before the treatment, we have to know that in fact, there is not only one localization on the face, and everything is linked in the face. And I usually say that the face and the visage is an illusion. If you have to play for a specific place of the face, you have to take part of everything around the target you have to treat. So if you want, for example, to treat the nose, you have to think about the junction between the nose and the forehead, between the nose and the lip, but also the lateral projection of the mid-face. So everything is linked, and we have to take a very global vision of the face to find the most subtle and precise way of treatment. The history of the highlighting concept is coming from this philosophy of less is more, and we have published this philosophy. In fact, this is the philosophy is to be more effective, natural, and safer, of course, because if you use a lower amount of product, you will be safer and you decrease the risk of embolization, and of course to be less costly for the patient. This less is more concept is donc subtle volumetry analysis with codified techniques in order to control the quality of the product, to preserve the facial volume while respecting the facial expression, which is, we have to keep in mind the facial expression, and to keep this natural looking and subtle results. The light is a key point of the beauty of the face, and the makeup. They know this with the makeup, which is camouflage technique, and the makeup artist, they well know how to erase some specific region of the face, or to highlight other region of the face. And in our philosophy, and we have developed with FillMed this highlighting approach, we have to play on specific anatomic place of the face. What is the highlighting? This technique brings light to specific zone in order to create specific highlighting. And you can see we can distinguish the contouring technique. We will play on the shadow, and the highlighting technique is to play on the light. So you will augment, improve the light on this philosophy, and you will create a new light effect. Light, you do it with makeup. Okay, sorry. Okay, so this new protocol by FillMed is coming from the makeup techniques, and the needle will replace the brush, and we try to be as efficient as the makeup artist. But all the time we are doctor, we have to take in our mind the patient needs, the patient wishes. We have to know the injection technique, and we have to use the right product. And in this philosophy and this protocol of highlighting is directly linked with the quality of the FillMed range, and especially with the trial technology, which will induce the product exactly what we need in this kind of protocol. So this injection technique is focused on, in the injection, you will inject exactly where the distance between the skin and the deep layer are very short. So immediately you inject the product under the skin, you touch the structural support. So this is, for example, the lateral region of the zygomatic and mid-face area, or for the lip, this region. Immediately when you inject a small amount of product, you immediately have an effect, a beneficial effect. So the technique is not to inject a place where there is a deep region with no effective result, but to find exactly where in the face, with very small amount of product, you will have the good result. Of course, the anatomy, and Sébastien Cotofana show us, this is very important to know the anatomy, but the anatomy is well known to inject, to know where we have to inject, but also to know where are the danger in the face, and especially the branch of the facial nerve. So if the concept is good for the aesthetic, you have to be sure it's also good with anatomy landmark. The key point for this this facial analysis is the forehead, the lateral region of the eyebrow, the mid-face, and especially this lateral zygomatomalar area, the nose, the bridge of the nose, the lip. Of course, these regions are on label or off label, depending to the product you can use. You can see in the simulation and the location of the product we have done with this kind of FillMed highlighting protocol. This highlighting can be done on focus area, for example, the lip contouring, or for the eyebrow. This is like a botulinum toxin lifting effect. If you just inject, you restore the captation of the light on the orbit. Or you can make a global highlighting with specific injection with small quantity of product for this kind of injection. For example, in this patient, we inject 0.1, 0.1, 0.2, 0.1, 0.1. So with very small quantity of product, immediately you improve the face. Another example of highlighting global effect. This is another one with 2 syringes. And I show you my difficult case because this is for this symposium FillMed, we have to find and to show, to share a case report. So this is a 30 years old patient. She's nice, but she looks sad and she have a lack of presence. So you will try to manage this patient and to make this highlighting approach.
So all the complication of the
so I will cut the sound of the video
of the hyaluronic acid are done because of
okay. So you see the patient before the treatment. So first of all, we have to make the landmark, and the most important I told before is the vascular landmark and the facial artery division of the face, which is coming from the external carotid. And you see she's just running before the masseter muscle, and she's between the DAO muscle and the masseter muscle. And this artery is, she has an elastic direction to make adaptative to the facial expression. She make the division for the lips. and she's running in the nasolabial area, and in this location she's difficult because sometimes she's deep, sometimes it's superficial, sometimes she's up or down of the nasolabial fold. So the location of this fascial artery is not all the time the same for the patient. And then she is running deep next to the bone until the location of the radix and the glabular area. Okay, so you can see the division of the facial artery. And this is what we have to avoid to make injury. Okay, and this is the nerve line, supra-infraorbital nerve line. So we have to avoid also not to make an injury for the nerve. And then in the left side of the patient, we will apply what we will inject and where we will inject for this patient in this highlighting protocol. Sorry. This is the problem of, sorry. Okay, so I turn here. So here you will see what we will draw. The drawing of the midface, the A-brow, and the nasolabial fold, and where we inject small amount of product. You see it's just up to below to orbital bone, and just to lift up the A-brow with 0.1, 0.2 cc. It's a very good effect. This line, this is on the line of the beautification. You have we will change the shape of the face, which will be more triangular, more V-line, more attractive, and this injection to project anteriorly the face. 0.2 cc, 0.2. Okay, and to improve the lip, the earth of the lip, I inject in this case the contour and the volume of the lip for the upper one, and the contour for the inferior one. So now this is the video technique, and you will see
the A-brow. So
A-brow injection.
Border is there. Be up to the.
Okay, so we inject in this indication, we can inject the on-label indication. This is fine lines to fill the glans area. Oh, sorry. Okay. So you inject with the needle. We have no danger because we are out of this line from the pupillar line and the supraorbital and infraorbital nerve. You have no danger in this area, so you can inject with safety with the needle, and we inject 0.1, 0.2 cc in this area. Okay, and you see immediately the light captation we can obtain with a few quantity of the product, and the result is visible immediately. You have the lifting effect from the right side to the left side. Okay, and this line I showed you before. This is the beautification.
Frédéric, you should cut just a little because we are a little late.
Okay, I will cut in a few minutes, so you will see all my procedure. Sorry, and we will finish with the lip because we finish in less than 1 minute. This is the border of the inferior lip here. Okay. So this is universal here. This product is fantastic because you can use it everywhere in the face and also in the lip. And you see you will improve the volumation and the contour of the inferior lip, and 2 points for the superior lip, and then it will be finished in a few seconds. In this case, I just want to improve the earth of the lip with 0.1 cc of for each size. Okay, so this is the patient just after, and you can see the result immediately. You improve the radiance and the attractive effect only with 2 syringes of the face. Thank you for your attention.
Frédéric. Very interesting, and the study of the face is the basis of our good outcomes. So now I am very happy to introduce Dr. Christopher Rowland Payne, a dermatologist from UK.
Thank you very much for inviting me. Thank you to FillMed, and thank you to you, Chairman, and all the long-suffering listeners. So my name is Christopher Rowland Payne, and I would like to talk to you a little bit about some very small maneuvers that you can do at the angle of the mouth to create some strategic changes. And these are very small quantities of filler. Next slide, please. So we can make quite a big difference with some small details. Next slide, please. The essential problem in the face and in the mouth is that a grape is full of liquid. Next, please. But a raisin is wrinkled as it loses its volume. Next slide, please. Next, you can see here my 12-year-old daughter with good anterior projection because there's plenty of volume. Next slide, please. And my mother, whose volume has gone and the tissues have fallen. And this can be seen at the medial part of the lip, but more so at the angle of the mouth. Next slide, please. The lips are a very important part of the face. Next, please. They show our identity, personality, sensuality, and emotion. Next. The upper lip is suspended from the columella, and it's opposed by the orbicularis oris. The problem for the lateral lip, though, is that it is only suspended by the soft tissue of the cheek, which is going to fall a lot, and it's opposed by involution of that fat. Next, please. Gravity, next, and next. Sleeping and depression of the angular oris muscle. All of these factors mean that in youth there is a smile, and next, in age, the angle of the mouth is downturned. Most of the attrition around the mouth occurs at the edges of the mouth in terms of this descent. Which materials shall we use? Well, we can use excellent materials by FillMed, excuse me, FillMed Art Filler Lips and Art Filler Lips Soft, excellent. Next. These two fillers are different in their G' and chain length, cross-linking. Next slide, please. And this translates, next slide, please, into their consistency. So the one called Lips is stiffer and more supporting, whereas the other one is softer and more spreadable. Next slide, please. And here you can remind yourself of which is which. Next slide. The excellent product NCTF can be used to improve tissue quality on the surface. Next, please. So how do I do what I do around the angle of the mouth? It is in 5 steps. Next, please. Next. Next. The aim is to restore the smile by lifting the angles of the mouth. And in step 1, next, we have the egg line. Now the egg line is the labio-mandibular line at the beginning near the mouth. And you have all seen old men who have egg trapped at this point. I call this the egg line. Next, please. Using art filler lips, next, please, we can put a little area here, inject in retrograde at the angle of the mouth, running back. Next. That's the first step. Step 2, punctate superficial subcutaneous enhancement. So what we're doing here is using a little bit of something like art filler lip soft to produce some further elevation of this shadowed area at the angle of the mouth. Next slide. Here, these are punctate injections instead of a threading one now. And it's helpful sometimes to do multiple injections. Each of these is a very small amount, perhaps 1/100th of, or 2/100ths of a mil. Next, please. The third step is to improve skin quality. And so there's nothing better for this than, next slide, NCTF, next slide. And so these are subdermal or dermo-subcutaneous junction multiple injections, each a tiny amount, many injections. This is a place where fine lines start to develop early. Next slide, please. Next slide. Submucous enhancement, for example, using art filler lips, is a very good way of bringing forward the angle of the mouth in the inferior part. And you can use larger amounts here, still much less than 0.1 of a mil, to bring forward the shadowed area. And then the key step in the angle of the mouth treatment is the Mona Lisa smile. Next slide, please. Next. Art filler lips is a useful one for this. So the angle of the mouth is identified. A point 2 or 3 millimeters superior is chosen as the entry point. The needle is threaded along the white line, and then in retrograde, the filler is inserted. And then the needle turns into the vermilion to form a small bolster to create a new angle of the mouth, which is slightly superior to the original one. Next slide. Next slide. We see here in the Mona Lisa, we can see the angle of the mouth is elevated. So here is a virtual video explaining the angle of the mouth being identified. Next slide. A point is chosen 3 millimeters superomedial to the angle of the mouth. Next slide. The needle is inserted as far as into the white line space and advanced to the hub. Next slide. And in retrograde, in a threading fashion, some filler is injected along the white line. Next slide. Before removing the needle from the skin, the angle is changed slightly and the needle is advanced medially into the superficial vermilion, and some further filler is inserted to form a bolster. Next slide. The filler is implanted in retrograde there, and this helps to define the new angle of the mouth. Next slide. So before, next, and after. And this is a very small amount of filler. Next. Before and after. Only 0.5 of a mil is used in each angle of the mouth. So 0.1 would cover both angles of the mouth. Next slide. Next slide. Another example. Next slide. Next slide. Here it is again. The angle of the mouth is identified. A point is chosen 2 or 3 millimeters superomedial, and the needle is inserted and threaded along the white line as far as the hub. And then gradually, in retrograde, a thread is put in, and before the needle is removed, the angle is changed, the needle advanced into the vermilion, and a bolster inserted to establish the new position of the angle of the mouth, which is now 2 or 3 millimeters superomedial to its original point. Next slide, please. So in a downturned mouth, the upper lip is longer than the lower lip. Next slide. Next slide. In an upturned mouth, the upper lip is shorter than the lower lip. So in order to achieve that, next slide, at the angles of the mouth, 2 millimeters is stolen from the upper lip using this technique, next, and given to the lower lip, so that the top lip becomes shorter and the bottom lip longer. Next slide. Next slide. We're shortening the upper lip and lengthening the lower lip. Next slide. Next slide. So instead of a long upper lip, we end up after this procedure with a shorter upper lip. Next slide. So here are some photographs of a before and after, and I think you can see that it's a little bit elevated, but actually I was tricked because it was more elevated than I thought. So I'm drawing a blue line here from a distance which is a certain distance, let's say 3 millimeters below the medial part of the lower lip, and I'm extending it to that small mole. And I see in the after picture that actually I'm not respecting the same line. So next slide, I've now adjusted it, and you can see that actually the angle of the mouth has risen more than I thought. Next slide. Quite a lot. Next slide. 1 or 2 millimeters by this procedure. Next slide. Next slide. So these pictures of Mona Lisa were without steps 1 to 4. If you add steps 1 to 4 as well, it's better. Next slide. So in conclusion, next slide, it lifts the angle of the mouth by 1 or 2 millimeters, upturns the angles of the mouth, widens the mouth, gives a less sad or disapproving appearance, next slide, and a more youthful or contented look. Last slide. Next. So steps 1 to 4 use each side half of 0.1 of a mil. If we do both sides with step 1 to 4, it's 0.1 of a mil.
Dr. Payne, we have to end.
And that is it. That next slide. We repeat this twice a year. Thank you.
Great. Thank you. Thanks to all the speakers. It has been a very interesting session. I mean, we touched many topics that are very important in our clinical practice. So I found 2 questions. I don't know if we have time to. Okay, great. So thanks a lot. Thanks to FillMed, and I think that they gave us the opportunity to improve our skills, and thanks to all the speakers. Thank you.
Thank you, Emanuele. Thank you to FillMed. Thank you.
Thank you. Bye.